name is Ayako Konishi, and I'll be presenting this work on behalf of my father, Professor Tomokazu Konishi. We're joining from Japan and will be presenting online. Thank you for allowing me to participate remotely. Today's talk concerns a collaboration with Akita Prefectural Cardiovascular and a Cerebrovascular Center, which serves as a core hospital in this region. Akita Prefecture is known for having a particularly high incidence of stroke and heart disease. All the data I'll present today pertains to patients who were transported to this hospital by emergency medical services. I am an informatician with a background in biochemistry. This type is extremely rare. In fact, I have never encountered one at academic conferences. There are probably only a handful of informaticians with a background in biochemistry. Today, I will address 3 key questions. 1. How should we measure lipoproteins more accurately? 2. Can we develop improved methods for measuring them? And last but not least, how should we treat patients and those at risk based on these measurements? As you know, lipoproteins are a transporter of lipids. They carry triglycerides and cholesterol. Both are either absorbed from the food in the small intestine or synthesized in the liver. These are transported through the bloodstream. Naturally, as blood is an aqueous system, retaining oil within it is a quite challenge. This protein complex accomplishes that. It is a protein present in a very large quantities, and it is also a very large protein. So, how have lipoproteins traditionally been measured? Because they are primary carriers of cholesterol, they have long been considered potential contributors to various diseases. Therefore, accurate measurement of lipoprotein is of crucial importance. Lipoproteins have traditionally been measured using ultracentrifugation. This method applies extremely high centrifugal force to serum containing a very high salt concentration, thereby creating a salt gradient. Lipoproteins then separate by floating according to their specific gravity. The entire process requires several days to complete. One representative study published in 1975 established this approach as an industry standard for lipoprotein fractionation. For many years, whenever a new method was proposed, validation required demonstrating agreement with this ultracentrifugation technique. Ultracentrifugation cannot process large numbers of samples efficiently. Therefore, a simplified method was developed for screening purposes. This approach selectively solubilizes certain lipoproteins using a specialized surfactant, then quantifies the released cholesterol and triglycerides with colorimetric assay. The method enables automation and the processing of large sample values. Most importantly, it produces results that are fully consistent with those obtained by ultracentrifugation. Now then, as a biochemist, I do have some reservations about the ultracentrifugation method. Why rely on such a laborious technique? If one were to prepare a density gradient in Perkle beforehand, separation could be achieved much more rapidly. In fact, this is a type of approach we typically use in our lab. Surely someone must have attempted this in the past. Why, then, did it not become widely adopted? Above all, when handling protein complexes of this kind, high concentration must be strictly avoided. This is because proteins undergo salt precipitation at specific concentrations, depending on their type. Applying strong centrifugal force to a complex under such condition will almost certainly lead to its destruction. For these reasons, researchers with background in biochemistry should not rely on this method. Here is another method, high-performance liquid chromatography, HPLC. This approach enables lipoprotein separation in a much shorter time and, importantly, avoids the need for high salt concentrations. However, this method was also required to demonstrate consistency with ultracentrifugation. As a result, it was evaluated using a rather problematic and arbitrary analytical framework. Therefore, I conducted an analysis using a data-driven approach. This method involves modeling the output with the minimum number of normal distributions required to explain the data. Analytically speaking, it is an approach grounded in exploratory data analysis, EDA. As a result, 12 distinct classes of lipoproteins were identified in human serum. HPLC is capable of distinguishing among these 12 classes and quantifying both triglycerides and cholesterol within each. This figure compares our result with the conventional enzymatic method currently used for screening. It is clear the conventional method aggregates multiple lipoprotein classes together rather than distinguishing them individually. HDL is particularly problematic. Most of the values reported as HDL actually corresponded to another, more abundant class. In other words, the conventional measurement method does not provide accurate results. This result suggests another possibility. What was measured as HDL by ultracentrifugation may in fact have been a mixture of degradation products derived from multiple classes. These classes likely could not be separated unless they are degraded, which seems to explain why Perkel gradient could not be applied successfully. In reality, each class contains numerous proteins, and then the differences in density between classes were probably minimal. These figures show the result of principal component analysis, PCA, based on our measurement data. In both plots, black points represent patients, while color points represent controls. The figure on the left shows HPLC result. Here, the patient and controls are clearly separated. This means that individual at risk can be identified, and the effectiveness of treatment can be also confirmed. Here, patients and controls are totally mixed. Although the paper initially caused quite a stir, the ACC and the AHA ultimately removed LDLC from the clinical guidelines. In contrast, Japan continues to rely on conventional LDLC measurements. However, this practice lacks solid evidence and does not reflect the current international consensus. The specific class was abnormal varied slightly between patients, likely reflecting the differences in underlying pathology. However, two groups were most commonly affected. The first was HDL1, the precursor to mature HDL. A reduction in its quantity was consistently associated with increased risk. The second was LAC1, a small complex formed by cholesterol and a plasmin inhibitor protein. I suspect it functions somewhat like a puncture repair kit where the blood vessels ruptures. However, in doing so, a supply cholesterol to thrombus while simultaneously protecting it from degradation. An increase in this class was also a significant risk factor. Unfortunately, current screening method cannot process either of these classes. High-performance liquid chromatography is required. LDL was not found to be significant. In particular, current LDL measurements are clinically irrelevant. Statins are effective in lowering LDL cholesterol. However, they probably do not prevent the actual onset of disease. How can we develop new methods? Conducting large-scale screening via HPLC is impractical. At present, we outsource HPLC to a company. However, requesting even 100 samples would overwhelm their capacity. HPLC remains a rather troublesome method for routine use. I am therefore developing an electrophoresis-based method. It will be completed shortly. We do not intend to apply for a patent. Instead, I plan to publish the method in a scientific paper, so please look forward to it a little longer. How can we treat potential patients? Our inpatients have shown improvement within a relatively short period of time. We are now investigating whether dietary factors might be responsible for this effect. I am in the process of writing papers on those findings, so please bear with us a little longer. At the same time, we are actively seeking hospitals to collaborate on further research. If your institution is interested, please contact us. At least one thing is very clear. As we grow older, it may be wise to reduce our intake of fats. This concludes my presentation. Thank you so much.
Hello, Assalamu alaikum. It's my pleasure to present this presentation for you. Bismillah ar-Rahman ar-Rahim. My talk is about the impact of increasing body mass index categories on left ventricular diastolic function. My name is Dr. Ahmed Abdel Hamid. I am a cardiologist specialist in Egypt. I have a MC Cardiovascular Medicine and MC Anesthesia and ICU. There is currently a big pandemic of obesity. Obese patients are particularly at increased rate of HFpEF. Body mass index, the most common way to assess obesity, is not considering the increased proportion of body component. Thus, it may be different when fat of body is elevated or mass is elevated, even if the body mass index is equal in both cases. So, we studied the effect of both probability on diastolic function. Bioelectrical impedance analysis calculates the percentage of body components separately. Thus, it helps us to differentiate between the increased body mass index due to fat accumulation or increased mass muscle. Using this technology present in body composition analyzer or M-body enables us to study both groups separately. The aim of our study was to assess the impact of increasing body mass index due to increased body fat versus muscle mass on left ventricular diastolic function. Our study design was a single-center comparative cross-sectional study conducted at Cardiology Department at Penn University Hospital during March to July 2023. This study includes 150 asymptomatic medically free individuals divided according to body mass index, fat, and muscle percentage to 3 groups. Group A, 50 individuals with body mass index less than 25. Group B, 50 individuals with body mass index more than 25 due to increased fat. Group C, 50 individuals with body mass index more than 25 due 25 due to increased muscle mass and normal body fat. Our inclusion criteria: age from 20 to 40 years old, both genders are eligible, asymptomatic free medical patient. The exclusion criteria was patient refusal, diabetics, hypertensives, any documented ischemic heart disease, reduced LV systolic function, age less than 20 or more than 40, rhythm other than sinus rhythm, congenital heart disease, symptomatic patient with dyspnea or chest pain, individuals with increased both fat and mass percent and muscle mass percentage. Ethical consideration: after obtaining the informed consent from participants, the study approved by the ethical committee on research involving human subjects in Penn Faculty of Medicine. Candidates were subjected to the following: history taking, stressing on symptoms, examination, high blood pressure, body composition analyzer by InBody, proper cardiac examination for all participants, a random blood sugar, ECG, transthoracic echo, conventional echocardiography, compressing on the diastolic function parameter, and speckle tracking echocardiography by peak systolic global longitudinal strain of LV using 2D speckle tracking. Measurement tool was the diastolic parameters with left atrial volume index, peak systolic global longitudinal strain. Study outcomes: our primary outcome was the degree of diastolic function and left ventricular compliance. Secondary outcome: degree of biventricular pressure overload by measuring left atrial volume index and tricuspid regurg velocity. Peak systolic global longitudinal strain by using 2D speckle tracking. Correlation between increasing body mass index and diastolic function. Our result: the demographic data. As our study had a sex and age matched groups, there was no statistically significant difference between three groups as regarded to age and gender distribution. Regarding body mass index difference, our study had an A group with normal body mass index and B and C groups with high body mass index. So individuals of group A had statistically significant lower body mass index in comparison to those of group B and group C. But individuals of group C had a statistically insignificant difference regarding body mass index in comparison to those of group B. This ensures that any difference in the diastolic function between B and C groups wasn't due to difference in body mass index. Regarding to body fat percentage and the muscle mass percentage, as regard the analysis of InBody result, by analysis of body fat percentage of the three groups, we found that there was a statistically significant increase in group B in comparison to the other two groups. By analysis of muscle mass percentage of the three groups, we found that there was a statistically significant difference increase in the group C in comparison to the other two groups. Regarding blood pressure and LV function with Samson method and with global longitudinal strain by 2D speckle tracking, there was no statistically significant difference between the three groups. Regarding average E to E prime and septal and lateral E prime, as regard the post-hoc test, average E to E prime was significantly decreased in C groups in comparison to A and B groups. It was significantly decreased in A group in comparison to B group. As regards septal E prime and lateral E prime, there were significantly increased in C group in comparison to A and B group. Septal E prime and lateral E prime were significantly increased in A group in comparison to B group. And as regard to A wave, E wave, and A to E. As regards E wave, there was significant increase in C group in comparison to A group and B groups. A wave was significantly decreased in B group in comparison to A group. And as regards A wave, there was significant decrease in C group in comparison to A group and B group. A wave was insignificantly decreased in B group in comparison to A group. As regards E to A ratio, there was significant increase in C group in comparison to A and B groups. However, as regards the A and B groups, E to A ratio was insignificantly decreased in B group in comparison to A group. As regards tricuspid regurg velocity, there was statistically significant difference in C group in comparison to A and B group. As regards the correlation between the body fat and lateral E prime and average E to E prime, the body fat percentage showed a significant positive correlation with value of average E to E prime, which indicates that average E to E prime increased progressively with increased body fat percentage. The body fat percentage saw a significant negative correlation with value of lateral E prime, which indicates that lateral E prime decreased progressively with increased body fat percentage. As regards the muscle mass correlation with lateral E prime and average E to E prime, the muscle mass percentage show a significant negative correlation with value of of average E to E prime, which indicates that average E to E prime decreased progressively with increased muscle mass percentage. The muscle mass percentage saw a significant positive correlation with value of lateral E prime, which indicates that lateral E prime increased progressively with increased muscle mass percentage. Now we will present one case from each group. This patient who was from group A. He has a body mass index less than 25. His echocardiographic parameters was all are normal. The conclusion is preserved systolic function with normal global longitudinal strain and normal diastolic function with normal all diastolic function parameters and normal left atrial pressure. Second case from group B, which has increased body mass index due to fat. The conclusion was preserved systolic function with normal global longitudinal strain and normal diastolic function with normal diastolic function in spite of decreased lateral E prime with normal left atrial pressure. The third case from the group C, which has a high body mass index due to increased muscle mass percentage. The echo conclusion show preserved systolic function with normal global longitudinal strain and normal diastolic function with normal diastolic function is in spite of increased left atrial volume index and normal left atrial pressure. We have some limitation in our study. The aim limitation of our study was the small proportion of population who exercise or bodybuilding treat. Also, the sample size was calculated according to statistical base and was sufficient to assess the systolic function and subclinical systolic dysfunction with global longitudinal strain in non-comorbid obese. Doing similar studies with larger samples, which wasn't available in our study, will empower the result and enable us to confidently a role model for use in the wider clinical context. Due to limited age group of muscle builders, we couldn't discover the long-term effect of aggressive sports on the systolic function. Our conclusion and recommendation, we conclude that we know that body mass index may interfere with the diastolic function, but this group has increased left atrial volume index and tricuspid velocity regauge, which may indicate chronic biventricular pressure overload. Regarding body fat, there was significant positive correlation between body fat percentage and average E to E prime, and negative correlation between body fat percentage and the lateral A prime, which indicates that increasing body fat was badly affecting the diastolic function. So it is not fair enough to put muscle builders in the same group with increased fat persons only due to their equal body mass index, as our study showed a significant difference between both groups regarding the diastolic function parameters. We recommend that having healthy individuals for developing medical conditions, it is recommended to do more studies with a larger number of cases and larger varieties of body mass index, as both B and C groups have body mass index more than 25 but less than 30. This is due to the limited people who exercise in our country. Follow-up of the study groups should be done for a long time, so advanced age may have the same results or discover new information about the stomach function. Patients with increased fat and have weight reduction programs should be studied to show the effect of weight reduction on the stomach function. Thank you for your listening.
Before I'd like to tell my topic, I'd like to tell a punchline which says intramuscular infections, where microbes throw molecular tandems called resistant genes. So here, these intravascular infections stem from persistent bacterial invasion and they cause high morbidity. So predominantly, they are bacterial in origin, which means they demand urgent care and can be treated accordingly. India lacks molecular insights, especially to bloodstream infections pertaining to intravascular origin. So this study profiles both the phenotypic mechanisms and the resistant genes, which will advance stewardship and especially target on infection control practices. So this study was conducted and it is a cross-sectional observational study done for a period of 7 months at Rajiv Gandhi Government General Hospital, Madras Medical College, Chennai, Tamil Nadu, India, after getting ethical committee approval. So here, the inclusion criteria, only the boldest veins and the boldest bugs made the eligibility list. So patients above 18 years of age and infective endocarditis diagnosed via clinically or through echocardiogram and CRBSI, which is catheter-related bloodstream infections for patients who had central line for more than 48 hours were included in the study. Patients less than 18 years of age, extravascular bloodstream infections, and pre-admitted central venous catheters. Sorry guys, you're excluded from the study. Blood, bugs, and catheters collected with consent, processed with precision, and decoded for resistance. We followed modified Duke's criteria, which has 2 major and 2 minor. 2 major included positive blood culture where organisms, microbial confirmation of organisms were seen. And the second major criteria was there was evidence of vegetations in the echocardiogram. Coming to the minor criteria, we had 5 minor criteria, out of which predisposing factors like IV drug abusers was included, fever, that is temperature more than 38 degrees Celsius, and vascular changes like septic emboli, thrombotic emboli, and also the Janeway lesions, painless lesions, all were included in vascular criteria. Immunological response where glomerulonephritis, Osler's nodes, Roth spots, all these were included, along with microbiological evidences, especially serology with increased in CRP, C-reactive protein. So the sample collection was based on the American Heart Association and the European Society of Cardiology, where they recommended 3 sets of blood culture, each set having 1 aerobic and anaerobic with 10 ml of blood each, and there should be 1 hour gap between the first and the last drawn blood culture. So coming to my results and discussion, based on the patient's demographic and clinical characteristics. If you could see, almost 50%, that is almost half, more than half of the patients were in the age group of 40 to 60 years. This could be because of the age-related vascular changes like atherosclerosis, endothelial dysfunction, and vascular degeneration. And also, this is the age group where maximum comorbidities like diabetes, hypertension, and chronic kidney diseases occurred. And also, midlife is the place where immunosenescence occur. Immunosenescence is a immune response where there is an immune deficient responding to severe bacterial infection. And there can also be increase in this age group because this is the age where maximum interventions are performed. Though age above 60 years, though they were more immunocompromised than 40 to 60, were low, which could be because of the lower invasive procedures which are usually done in these age group of patients. And also, this is the age group where the healthcare seeking behavior is very low because they usually get referred to a primary healthcare center and not in a tertiary healthcare center like us. And also the caregiver limitations because of high mortality, they could have not reached a tertiary care center. Coming to the gender predominance, male showed 70%, which could be because the tendency in India for a male to seek a healthcare facility is they seek at a later stage of disease, that is when they have a severe disease. And also the immunological variation in male where they are more prone to develop severe bacterial infections. Coming to the ward-wise distribution, nephrology topped. Nephrology department was 75%, followed by cardiology and ICU. This could be because patients with acute kidney injury presenting in nephrology, where immediate hemodialysis should be done, where they would have given central line, following which central line related infections would have occurred because of the exposure to the nosocomial pathogens. Coming to the clinical diagnosis, almost 85% was because of CRBSI. So it is catheter-related bloodstream infections more than the infective endocarditis, which aligns with the ward-wise distribution as nephrology, where most of the central line related infections happened, contributed, and next followed by cardiology, where all the infective endocarditis contributed. If you could see the patient stratification by fever distribution, most of them were in the age group of 0 to 7 days, that is almost 60.4%, which shows there is early onset bloodstream infections. This could be because fever can serve as an early recognition symptom in hospitalization, and also especially in patients who have central line and are having a hemodialysis, they are given high awareness of to seek a medical attention immediately when a symptom like fever happens. So this could probably align with our fever more in the duration of 0 to 7 days. If we could see the central venous catheter characteristics, we may see that the catheter duration, if the catheter duration is more, that will directly relate to the number of growth. So more the duration, we got more growth. Out of 101 sample in our study, 49 had growth, and most of them were in the catheter duration of 41 to 50 years. This could be because biofilm maturation happens over time. And also there can be hub manipulation, skin migration, and hematogenous seedling, which can lead to progressive or persistent bacterial infection. And also our population was mostly of nephrology patients with a probable chronic or acute kidney injury, which could have led to an already existing immunocompromised state, making them more vulnerable to nosocomial infection and possibly bloodstream infection. Coming to the laboratory findings, the severe leukocytosis directly correlated with the number of organisms and severe infections we have isolated. And also, the microbiological profile of bloodstream infections showed almost half of the blood cultures we received did not have any growth. This could be because of prior antimicrobial exposure, or there could have been low bacterial load when the blood was collected. And also, there could be growth of fastidious organisms, which we could not isolate by conventional microbiological culture. And if If we could see the distribution of microorganisms patterns, it is Klebsiella pneumoniae, which tops the list, followed by Pseudomonas species. So these two are potential nosocomial pathogens which are isolated in a hospital, and Staphylococcus aureus being the most common cause of CRBSI, that is catheter-related bloodstream infection and infective endocarditis. Coming to the antimicrobial resistance gene prevalence, if you could see in this tabular column, we can say that Klebsiella pneumoniae, Pseudomonas, and Escherichia coli. So Klebsiella and Escherichia comes under Enterobacteriaceae family, along with Pseudomonas, all had ESBL genes. ESBL is extended spectrum beta-lactamase genes, where the most common genes are BLA-CTX-EM and BLA-TIL. So this is because these organisms will be resistant to third generation cephalosporins, beta-lactams, along with the beta-lactamase inhibitors like piperacillin, tazobactam, amoxicillin, clavulanate, all beta-lactam, beta-lactamase inhibitor combinations. So the only drug of choice for these patients will be a broader spectrum, that is carbapenems. Even carbapenem was found to be maximum resistant in Acinetobacter species. The genes which contribute to carbapenem resistance include OXA23, OXA48, KPC, and NDL, New Delhi metallobutyllactamase. So in India, the treatment for KPC and OXA gene detection would be ceftazidime avibactam, which is the drug of choice. And if there is ENDM, New Delhi metallobutyllactamase detected, we give astrionum along with ceftazidime avibactam. So this is the drug of choice, which is available in India for patients who have developed carbapenemase resistance. If we could see the Staphylococcus aureus here, it is 62.5% methicillin resistant. So we keep cefoxitin, which is a surrogate marker for methicillin. So this states that multi-drug resistant organism is on a constant high, especially in a tertiary care hospital. Coming to the antibiotic susceptibility patterns with resistant genes, if you could see in the figure 2, penicillin is almost 100% resistant in Staphylococcus aureus, which says it is because of the penicillinase enzyme, which is because of this, it is 100% resistant. And for ampicillin, it is 50% resistant in Enterococcus species, which could be because Enterococcus faecium is intrinsically resistant to ampicillin. And also 75% resistant in Staphylococcus aureus because of the acquired beta-lactamase production. Coming to the antimicrobial resistance pattern in gram-negative organisms, almost all the drugs which were given are resistant in Acinetobacter, showing that this is now the most potential nosocomial pathogen, especially multi-drug resistant, where antimicrobial stewardship and infection control should be made mandatory for us to have proper safety measures. Because of the selection pressure and high transmissibility, multi-drug resistant organisms are increasing in a tertiary care hospital. Coming to the clinical outcomes, almost 30% of patients needed escalation of antibiotics because of the multi-organ dysfunction, septic shock, and the persistent bacteremia. So to conclude, I'd like to say CRBSI, catheter-related bloodstream infection, and infective endocarditis causes major morbidity and mortality. So molecular detection has to be made into routine for faster surveillance because of the increase in multi-drug resistant organisms. Microbial stewardship and infection control practices are non-negotiable. Longer catheter duration is equal to higher dwell time is equal to higher colonization of microorganisms into the system, leading to more infection. So future focus should be on targeted antibiotics, novel therapy, and a real-time surveillance. So to conclude, I'd like to conclude with a punchline saying catheters stayed too long and bugs got too smart. So now it is genes versus germs in real time. So we should pull lines early, scrub the hub as though life depends on it, because it actually does, and bundle up infection prevention control protocols so that the bugs get rid easily, and we have to train the staffs to to troubleshoot things before the culture does. And finally, audit every day, act swiftly, and never let the resistance win. Thank you so much for the opportunity, and thank you so much for having me to have a word with my publications. Thank you.
I would like to thank Cardio Care for giving me an opportunity to present my work entitled A Plausible Role of Exosomal Mid-24-2 in Mitral Valve Dysfunction During Rheumatic Heart Disease Pathogenesis. So RHD is a autoimmune sequel to group A streptococcus infection, and it leads to throat infection that further leads to pharyngitis. If pharyngitis is left untreated, it leads to rheumatic fever. And several repeated episodes of RF can result into RHD, which causes damage to the valves of the heart, especially the mitral valves. So it is a global health problem for decades. RHD pathogenesis is still obscure. So this slide shows how, due to molecular mimicry, how autoimmune response is generated. Now here what happens during autoimmune response, autoantibodies go and bind to the endothelial cells lining the mitral valve of the heart. This leads to upregulation of various cell adhesion molecules and such as BCAM and ICAM, and infiltration of immune cells takes place into the valve, leading to scarring and RHD consequently. So, according to WHO reports 2025, RHD affects 36 million people globally, and it is the need of the hour to find pathogenic mechanism behind this disease. So nowadays, a small group of vesicles are released from mammalian cells that are called exosomes. They act as cell-to-cell communicators. Their size is very small, and the size ranges between 30 to 150 nm. So this is how exosome biogenesis is taking place. In the late endosomes, inward budding of the late endosomes leads to the formation of intraluminal vesicles, which incorporate various biomolecules like proteins, and these finally proteins are expelled out by joining to the inner membrane of the cell. So it consists of DNA, RNA. These exosome composition is like proteins. We have lipids. We have RNAs. So the role of exosomes has been seen in various cardiovascular diseases. However, their role in RHD is not known. So the aim of our study is to study the exosomal molecules in rheumatic heart disease pathogenesis. To attain this aim, following objectives were accomplished. Number one, to isolate and characterize exosomes from serum and pericardial fluid of RHD patients, and RHD patient serum stimulated human umbilical cord vein endothelial cells, that is HUVEC, to develop a in vitro RHD model. Second, to study the role of exosomes in endo-MT in exosomes treated HUVECs. Third was to profile microRNAs from isolated exosomes and validate their expression in deregulated microRNAs, serum, PF, mitral valve tissues, and exosomes treated HUVECs. Fourth was in silico analysis of selected microRNA target genes and to evaluate their gene expression in mitral valve tissue and exosome treated HUVECs. Fifth one was to investigate the functional role of selected deregulated microRNAs in exosomes treated HUVECs. So the inclusion criteria was in clinically confirmed cases of RHD for blood, mitral valve tissues, and PF were taken from the patients that were undergoing MVR, that is mitral valve replacement, in the department of CTVS PGI. So control PF was collected from non-RHD patients from the same department. That is CABG patients were used for collecting the samples. Then control mitral valve tissue was collected from cadavers with no pathological or morphological heart disease. And umbilical cords were collected from healthy mothers from the Department of Obstetrics and Gynecology PGI. The exclusion criteria was the patient suffering from any other autoimmune disease or any infectious disease, and those who are not giving consent were excluded from the study. An ethical clearance was taken from Institutional Ethics Committee. Informed and written consent was taken from the participants, and confidentiality of the data was maintained. Now come to demographic. Their total number of patients that were included in the study was 42 in number. And these are the demographic details. Here it's showing that the number of individuals range in age from 31 to 50 years, which were maximum in numbers. Females were more than males, and the age range was from 75, the maximum limit, and 17, the minimum. And there were more of MVR cases than DVR, where 10 were males and 23 were females in case of MVR, and in DVR there were 5 males and 4 females. Now coming to the first objective, which was to isolate and characterize exosomes from blood and pericardial fluid of RHT patients and controls, and RHT patients' serum stimulated HUX in order to develop in vitro model. So the samples were collected from RHT patients, and the isolation of exosomes was done from serum and PF using Mercury exosome isolation kit, and characterization of these exosomes was done through TEM, transmission electron microscopy, zeta sizer, and Western blotting. So, a 20 microliter of exosome PBA solution was put on carbon coated copper grids and allowed to stand for 1 minute. Exosomes were stained with 20 microliter uranyl acetate and left for 1 minute. The sample was air dried for 10 minutes and viewed under 10. A typical cup-shaped morphology was visible, and the size range was within 10 to 150 nm. That is the size range of the exosomes. Further, HUX were also isolated from umbilical cord because we are going to collect the exosomes from the media of HUX cells. So umbilical cord was taken, cannula was inserted in vein and washed with PBS. 0.2% collagenase solution was injected in the vein, and the cells were kept at 37 degrees Celsius for 30 minutes. Then it was washed with EGM, that is endothelial growth medium, and the effluent was cooled with collagenase and centrifuged at 1200 RPM for 3 to 4 minutes. The pellet was dissolved in 2 ml medium, transferred in 6 well plates at 37 degrees Celsius in 5% CO2 incubator. So cells were observed daily. It showed cobblestone morphology and showed confluency at the 4th day. Further characterization of HUX by using endothelial cell surface marker, that is NTCD33 again was used for that, and then the cells were visualized. So this is the unstained cells. These are DAPI stained cells. This is PE labeled CD31 stained cells, and when both of these images were merged, it showed that the isolated cells were HUX. So next was the generation of RHT in vitro model. For here, cells were grown up to 70 to 80% confluency, and RHT patient was added to the cells in 12 well plate to the final dilution of 1:5, 1:50, and 1:100 dilution for 6 to 12 hours, and the cells were viewed under EVOS. So it was found that the HUX cells that were treated with RHT patient serum showed rounded bodies at 1:50 and 1:100 dilution. However, regular morphology, that is cobblestone morphology, was observed in the cells in the HUX that were treated with normal individual serum. It was for 6 hours, and same trend was observed in the 12 hours. So, in order to confirm that the RHT in vitro model has been developed, RNA was isolated from these cells by Trizol reagent, cDNA was synthesized, and isolated RNA and relative gene expression was evaluated of certain genes that are associated with RHT pathogenesis. So, it shows significantly upregulated expression levels of pro-inflammatory cytokines as well as for the cell adhesion molecules, that is VCAM. So, it was confirmed that RHT in vitro model has been developed. Next, we had to take the media of the HUX cells because cells have excreted the exosomes in the media. For that, HUX were again grown up to 90 to 100% density medium containing 10% exosome depleted FPS. Then the medium was centrifuged at 2000 G for 10 minutes, followed by 10,000 G for 30 minutes. The debris was removed and the supernatant was passed through a 0.2 micrometer filter and concentrated. Exosomes that were obtained were further subjected to exosome isolation using Mercury exosome isolation kit, and characterization was done through TEM, zeta sizer, and Western blotting. So this slide shows that the typical cup-shaped morphology of the exosomes was seen, and the size ranged from 10 to 150 nm. Further, percentage intensity of the vesicle was in the same size range as that of the exosomes. And Western blot analysis against the CD63 exosome marker was done, where a protein band of 65 kilodalton was observed in all the samples. So it was confirmed that the isolated vesicles were exosomes. Next, there was exosome internalization experiment was performed by labeling exosome with PKH67 dye. And the HUVECs were then viewed under phase contrast microscope, and exosomes were viewed under green fluorescent microscopes, green fluorescent filters, and the images were merged. And this slide shows that the exosomes internalization has taken place in the HUVECs. Further, it was interesting to understand whether exosome, which is the component of serum, is responsible for such changes. So the HUVEC cells were treated with RHT patient exosome, that is R-exo, and normal individual exosome, that is N-exo, at 1:10 dilution at 48 hours. So it was found that the rounded bodies was observed in the cells that were treated with R-exos. Further, it was interesting to find out whether cell proliferation, what is the scene of cell proliferation taking place. So for that, cell proliferation assay kit was used, in which this number of cells was less in case of the HUVEC cells that were treated with R-exos as compared to that of the N-exos. For that, the decrease in cell number, we were interested in finding out the reason why the cell number decreased. So an exin 5 pi staining was done, and it was found that the total apoptosis was increased in case of the cells, in case of HUVECs that were treated with R-exo as compared to N-exos. Similarly, angiogenesis assay was also conducted, and it was shown that the HUVEC cells that were treated with N-exo showed beginning of angiogenesis, whereas no angiogenesis was seen in the cells that were treated with R-exos. So in order to confirm apoptosis and angiogenesis is taking place, we have calculated the relative gene expression of caspase-3 and VEGF. So it was found that the caspase-3 level was upregulated, significantly upregulated, and VEGF was downregulated in case of the cells that were treated with R-exo as compared to N-exo. So this shows that exosomes treated HUVEC showed some changes in the biological properties. Now, coming to the second objective, to study the role of exosomes in endo-empty in exosomes treated HUVEC. So similarly, the expression levels of VE-cadherin, that is endothelial marker, and SMA alpha, that is mesenchymal marker, their expression level was evaluated, and it was found that the SMA levels increased and VE-cadherin levels decreased in case of the cells that were treated with R-exo as compared to that of the N-exo. So endo-empty is taking place in R-exo treated HUVEC as compared to N-exo treated HUVEC. The third was to profile microRNAs from isolated exosomes and validate their expression in serum, PF, mitral valve tissues, and exosomes treated HUVEC. For that, microRNA NGS was outsourced from Biologia Research India Private Limited, and we were interested in checking the differentially regulated exosome microRNAs in the sample with delta CT value greater than 2. For that, the heat maps were generated in case of serum, PF, and media. So it was found that a common microRNA, that is MIR24-2, was the common microRNA that was seen in all the heat maps having the delta CT value more than 2, and it has role in endo-empty fibrosis. So exosomal MIR24 was selected as the potent microRNA for further analysis. Now the validation of expression level of MIR24-2 was done in serum, PF, exosomes treated HUVEC, and mitral valve tissues of the RHT patients. And it was found that it downregulated expression level of MIR22 was there in all the samples. Further, in silico analysis of selected microRNA target genes was done to evaluate their gene expression in mitral valve tissue and exosome treated HUVEC. For that, the selective exosomal microRNA target genes were predicted using MIRDB software and via literature search. So, furin was the predicted target gene of MIR24-2, which was calculated by MIRDB software. And to confirm whether this is the target gene, here the HUVEC cells were treated with MIR24 specific MIRs, and HUVEC cells were again another set was treated with HUVEC anti-MIR, HUVEC specific anti-MIRs for MIR24. So it was found that the levels of MIR24 increased in case of the cells that were treated with MIR24 MIRS, and furin, that is the target gene, its expression levels were down-regulated. And the opposite trend was observed when the cells HUVECs were treated with anti-MIRS for MIR24-2. So this confirmed that furin is the target gene of MIR24-2. Further, now it is important to know that the MIR24-2 gene, it works through furin TGF beta pathway. So furin is the latent activator of the downstream gene, that is TGF beta, which is responsible for fibrosis. So total RNA was taken and expression levels of furin and TGF beta was evaluated. So it was found that in the RXO treated HUVEC and in the mitral valves of the RHT patients, the furin level was increased as MIR24 levels were decreased, so its target genes furin levels were increased, and similarly TGF beta downstream gene also showed more expression levels in case of the target gene, that is TGF beta showed elevated expression level in case of the mitral valves that were taken from RHT patients. So this shows that decreased MIR24-2 uptake by endothelial cells augments the level of target gene and downstream molecule TGF beta in RXO treated HUVEC and mitral tissues of the RHT patients. Now, finally, to check the functional role of these deregulated microRNA, functional inhibition study was done for using MIR24 MIRS and anti-MIRS. Now, HUVECs were cultured in 5 cell settings: cells treated with RXOs, cells treated with NXOs, MIR24 mimics, transfected HUVECs, and RXOs and MIR24 anti-MIRS transfected HUVECs. And the cells were trypsinized and RNA was isolated from these cells and seen for any morphological changes or gene expression changes for MIR24-2 and furin. And for endo, anti, and fibrotic gene expression was also evaluated. It was shown that the cells that were treated with RXO showed distorted morphology. However, when they were transfected with MIR24 MIRS, the morphology of the cells improved. However, in the cells that were treated with NXO, there was regular cobblestone morphology. However, when the NXO treated HUVECs were transfected with anti-MIR24-2, then they distorted their morphology. So the gene expression levels of TGF beta, SMA alpha, V cadherin, MIR24-2 were evaluated. It was seen that the expression levels of MIR24 and V cadherin decreased when the HUVECs were treated with NXO and transfected with anti-MIRS for MIR24-2 as compared to NXOs. And in case of RXOs treated HUVECs transfected with MIR24 MIRS, in that case it was seen that there is upregulation of the MIR24. However, furin levels were decreased, TGF beta levels were decreased, and SMA alpha levels were decreased, and so VE cadherin levels were increased as compared to RXO treatment. So this study confirmed that there are some MIR24-2 is the gene that is responsible for bringing about endo-empty and mitral valve fibrosis. Further, Western blot analysis was also done to check the endo-empty markers and TGF beta markers. So it was found that there were elevated levels of TGF beta and SMA alpha in case of the cells that were treated with RXO and even in the mitral valves of the RHT patient as compared to that of controls. So MIR24-2 is seen to play a role in endo-empty in ECs lining the mitral valves of the heart and leads to mitral valve fibrosis during RHT. So further, the HE staining and Amazon trichrome staining was also done for mitral valve. So the hyalinization of the tissue represented that the tissues were undergoing fibrosis. So this is the summary in which the exosomes are taken up by the endothelial cells. They lead to endo-empty and they increase the level of SMA alpha and decrease the level of V cadherin. And similarly, mesenchymal cells forms fibroblasts that are converted into myofibroblasts that secrete large amounts of TGF beta and that leads to mitral valve fibrosis. So the outcome of the study was exosomal MIR24-2 may predict grade of RHT severity and appropriate measures can be taken to treat the disease at an early stage. So these were my publications. And again, I would like to thank Cardio Care for giving me an opportunity to present my work. Thank you. Thank you so much.
That was a remarkable talk, ma'am.
And coronary artery disease in myocardial infarction patients. And this title was accepted in previous international conference, but that was not presented, and committee granted this title. So I have presented this in this webinar. So what is acute myocardial infarction that nowadays very speedily rising, and prevalence rate particularly 3.8% in patient having less than 60 years of age, and that is devastating. In India, age standardized cardiovascular disease death rate is 272 per 1 lakh population, and that is higher than the global average of 235 per 1 lakh population. And there are wide disparity in prevalence of cardiovascular risk factor also across the different region. Like in urban area, that is prevalence is higher than the rural area. And according to latest 2022, that after COVID-19, that is continuously rising rates of the cardiovascular disease condition, acute myocardial infarction. Here, but various risk factors that are known and some are unknown. Cardiovascular disease condition is characterized by higher relative risk burden and earlier age of the onset. Nowadays, that is observed in very younger population, and higher case fatality. That death rate is very high, and higher premature death may occur in all parts of the India, particularly among the younger patients. So according to fourth universal definition of myocardial infarction, the diagnosis that involve both myocardial injury and ischemia, that is determined by the serial troponin measurement. Troponin level can check, and presence of ischemic symptoms and sign. So clinical sign and symptoms of acute myocardial infarction, we all know that chest pain and discomfort, that is very prominent symptom, and along with that shortness of breath occur, and feeling of lightheaded or faint condition may observe. This may observe in patient have also cold sweat, and pain and or discomfort in jaw, neck or back region, pain or discomfort in one or both arms or shoulder region. So based on the clinical history, we can identify the acute myocardial infarction. About risk factors, there are many risk factors for the acute myocardial infarctions, like some are modifiable, some non-modifiable risk factors. So modifiable risk factors include the smoking and or tobacco, and patient having comorbid conditions, having higher rate of myocardial infarctions, particularly hypertension, diabetes mellitus, abdominal obesity, and hypertriglyceridemia or hyperlipidemia. Patient having emotional conditions like psychological conditions, depression, and loss of locus of the control, particularly stress conditions, may arise acute myocardial infarction. That is one of the risk factor. Uh, there are many other social risk factors, that is particularly loss of loved one, job loss, or marital separations, or family conflict. So these all are mainly lead to psychological effect, and because of that psychological effect, person may have prone to acute myocardial infarction. Lack of physical activity, sedentary lifestyle, alcohol consumptions that are also responsible, modifiable risk factors for acute myocardial infarction. Non-modifiable risk factors, particularly advanced age and some genetic factors, hereditary factors. Male gender, the evidence suggests that male gender are more prone to acute myocardial infarction risk, and patient having a first degree relative having a myocardial infarction also may have one of the risk factor, that is first degree relatives, and familial hypercholesterolemia, that also one of the important non-modifiable risk factor. Other risk factors like moderately high level of plasma homocysteine level, and that is one of the independent risk factor for myocardial infarction. Some other risk factors that may be calcium level or bone density low, and consumption of cocaine, sexual activity, and vegetarian food. Some uh, risk or some evidence suggests these are also some of the risk factors for acute myocardial infarction. So we can evaluate acute myocardial infarctions using ECG, and in ECG there may be two patterns, that is myocardial infarctions can be divided into STEMI and non-STEMI. So STEMI, that is ST elevated myocardial infarctions. In that, ST segment is elevated and new left bundle branch block observed. Non-STEMI, that is non-ST elevation myocardial infarction, and the pattern that suggests that ST segment either elevated or there in ST elevated myocardial infarction, and non-ST elevated myocardial infarction. In that condition, either ST depression occur or T wave inversion observed. Biomarkers like cardiac troponin I and cardiac troponin T, that is one of the important diagnostic parameter, the value that may be consistently rising or falling pattern observed of the cardiac troponin, and rise in cardiac troponin indicate myocardial ischemia. With that, myocardial ischemia symptoms indicate the acute myocardial infarction, and here serial testing of cardiac troponin value at the 0 hours, 3 hours, and 4 hours, that give the better perspective. Creatinine kinase MB level, that also important parameter, biochemical parameter for diagnosis of myocardial infarction. Other than this, angiography is important for the diagnosis of the myocardial infarction. Other than 2D echocardiography, that is also one of the non-invasive imaging testing, and in that we can observe the abnormality like in regional wall motion abnormalities, and either regional wall motions are decreased, that indicate the hypokinetic or kinetic, dyskinetic, or aneurysmal, and absence or reduction of systolic thickening, that also we can observe with the regional wall motion abnormality. And from that we can identify there is enlargement of left atria, and the fractions, ejection fraction of the left ventricles, that can also obtain with this 2D echocardiography. ECG changes is well known. Also indications for the diagnosis of the myocardial infarction, and particular lead indicate the artery, which artery block observed, coronary artery blockage, and we can identify with the help of ST elevation or ST depression or T wave inversion. So based on ECG finding, we can identify ST elevation myocardial infarction and non-ST elevation myocardial infarction. And in ST elevation myocardial infarction, particularly due to occlusion of one or more coronary arteries. So mainly due to atherosclerosis and transmural myocardial ischemia, that is also result in myocardial injury or necrosis. Non-ST elevation myocardial infarction, that is one of the ischemic conditions that may be causing the irreversible necrosis of the heart muscle, and the initial ECG that shows the ischemic changes like ST segment depression, T wave inversion, or transient ST elevations. So we can diagnose as STEMI and non-STEMI with this particular identification in the ECG level. Other way we can identify myocardial infarctions that mainly divide into another two types, like MICAD, that is myocardial infarctions with coronary artery disease, and MINOCA, myocardial infarction with non-obstructive coronary artery disease. So MICAD, that is occlusion of one or more coronary arteries on angiography. So in angiography, stenosis that may be more than 50%, sorry here that wrongly written, greater than 50% stenosis observed in MICAD, while in MINOCA, stenosis that is a blockage of the coronary artery that is less than 50%, or there may be nearly normal. So now from that we can differentiate MINOCA and MICAD, and here one of the important important test for the differentiation of MICAD and MINOCA, that is cardiac MRI, and from that we can easily identify MINOCA condition and MICAD. So MICAD cases that may be range from 2 to 12%, while here MINOCA cases that may be observed particularly 8 near to 8% or 2 to 8% cases. So that may be vary across different region of the world, and there may be different case prevalence observed. Now about the pathogenesis of myocardial infarction with non-obstructive coronary artery disease, that is MINOCA, and that is not one of the mystery conditions for the acute myocardial infarctions. Here we cannot easily identify, like patients don't have any blockage. There may be normal conditions, blockage is not so much prominent. There may be two different patterns are observed, like epicardial pattern and myocardial pattern. In epicardial pattern, normal or regional wall motion of the abnormality observed, and there may be due to coronary artery plaque, that is unstable or not detectable in angiography. That also one of the reason is coronary dissection and coronary artery spasm. Microvascular pattern, here suddenly microvascular spasm may observe, and that may result in acute myocardial infarctions, MINOCA, and Takotsubo syndrome, that is the sudden spasm in the heart muscles due to some physical stress or emotional stress, and coronary embolism, that is the plaque may break up, and that may block the coronary microvessels. Myocarditis, that is external factor responsible for MINOCA. About the pathogenesis, MICAD, that is myocardial infarction with coronary artery disease, mainly the risk factor, that is the atherosclerosis. Atherosclerosis occurs generally due to diabetes, smoking. These are other risk factors that are responsible for atherosclerosis, and some are well-known risk factors: hypertension, hyperlipidemia, some genetically also. And atherosclerosis lead to MICAD, either rapidly progress or slowly progress. So rapidly, slow progressions, particularly slowly, the intimal part of the artery that become thick and plaque formation occur, and that may block the artery, coronary artery. Rapid progressions occur without symptoms, like that may cause the plaque hemorrhage, plaque disruption, and non-occlusive thrombus. Thrombus formation may occur, and that may result in coronary block and result in myocardial infarction. Symptomatic, that is occlusive thrombus formations, that maybe thrombus occur that block the blood flow, and this lead to the rapid MICAD. About the treatment of MICAD and MINOCA, now almost treatment line is similar, and according to guideline, here the STEMI, ST-elevated myocardial infarction treatment include the drugs, antiplatelet agents, P2Y12 receptor antagonist, ticagrelor, then antithrombin drugs, enoxaparin, fondaparinux, indirect thrombin inhibitors, fractionated heparin, direct thrombin inhibitors, glycoprotein GP2B 3A receptor antagonist, then aspirin, clopidogrel, antithrombin, heparin, enoxaparin, then abscisimax, and aptifibatide and tirofiban. So these are common drugs used, but here in MINOCA, that depends on the etiology. The drug treatment is given, so there may be evidence-based treatment, like due to if the person found the plaque disruption due to in angiography and intravascular imaging, we can give the drug aspirins, statins, ACE inhibitors, and other beta blockers. And for spontaneous coronary dissection, aspirin, beta blockers, and clopidogrel ACE inhibitors. So according to conditions like coronary embolisms, coronary artery spasm, microvascular capacitance disorders in the endothelium, that is due to endothelial dysfunctions, and supply demand mismatch occur, that is for that we can give the treatment accordingly in MINOCA. So here we have done one study for the observing the comparison of prevalence, treatment, and outcome of the patients with myocardial infarction and non-obstructive coronary artery disease in our region, that is in Gujarat region, and this article is published in World Heart Journal. So according to that methodology of this study, this is the record-based retrospective study that at the Tulip Heart Center and ICU, Anand, in Gujarat state, and in India. After the ethical approval, the data was collected. So data was for MINOCA and MICAD cases that was taken after the COVID, that is January 22 to January 23, and patients over the age of 18 years old that was diagnosed with the acute myocardial infarction, and positive cardiac biomarkers were included, and some patients that has incomplete records and that were excluded. So total sample size was 363. So according to result of This study, patients having, as shown in this graph, myocardial infarction patients with coronary artery disease. In that case, the age less than 65. So in both cases, at a younger age, less than 65, MICAD and MINOCA both are rising, and particularly in MINOCA is more observed in younger patients compared to older patients. Um, Male patients are more affected in our study compared to female patients, and the conditions diabetes and hypertension are more common risk factors observed for the acute myocardial infarctions. So here there is some mistake in graph, like I have to the reference that was MINOCA, the blue color line. Then next, about the clinical symptoms, like chest pain is more common symptoms in both MINOCA and MICAD, and dyspnea that also observe. Vomiting, sweating, and palpitations are less prominent symptoms observed in some patients only, and cardiac biomarkers, particularly troponin level, that is more rise in MICAD patients compared to MINOCA patients, and CKMB level is also more in MINOCA, MICAD patients compared to MINOCA patients. So MICAD patients, both biomarkers, cardiac biomarkers was increased compared to MINOCA patients. According to angiography report, MINOCA patients have very no blockage or very normal report observed, and that was in some patients that generalized slow flow observed. While in MICAD patients may have single blood vessel block, single coronary artery, or double coronary artery block, or triple coronary artery blockage also. In echo, 2D echo, left ventricular ejection fractions, we have measured, and this parameter, left ventricular ejection fractions, were more in MINOCA patients, that is normal, according more than 55%, that are more in 49.1 cases of the MINOCA, while left ventricular ejection fractions greater than 55 in only 21.35% patients of MICAD. And also in MICAD patients, left ventricular ejection fractions are decreasing compared to MINOCA patients. About the treatment line of MINOCA and MICAD, as shown in this graph, most of the drugs, particularly MICAD patients, have more traditional drug like statins, beta blockers, aspirin, other antiplatelet agents, and AC inhibitors, vasodilators, and diuretics that are more observed in MICAD patients, while MINOCA patients had given the aspirin drug and beta blockers and statins. The outcome of this study, MINOCA patients have mainly come for follow-up, and compared to MICAD patient, while MINOCA patients have the re-hospitalization rates are less compared to MICAD patients, and death observed in MICAD patients, while MINOCA patients have not any registered death. So MICAD that involve obstructive coronary artery disease due to atherosclerosis, while MINOCA that is non-obstructive coronary artery disease and that having various underlying etiologies. This study found that MINOCA prevalence is 4.4%, while MICAD prevalence is 27.52% in this region, that is in Gujarat state of India. In MINOCA patients, but being younger and presenting with different clinical features compared to MICAD patients, and MINOCA were more prevalent in younger patients with higher proportions in female compared to male. While in male MICAD, that is more observed prominent cases in male patients, and traditional cardiovascular risk factors are also similar observed in both group, but MINOCA patients had lower level of cardiac biomarkers and few instances of ST elevation. So ST elevations is very less observed in MINOCA patients compared to MICAD patients, and MINOCA patients experience better outcome in terms of echocardiographic result and lower rate of mortality and rehospitalizations. So treatment trend, that is less aggressive, less treatment trend is observed in MINOCA compared to MICAD patients, and this study suggests the need of targeted therapy based on specific mechanism underlying MINOCA. So about the conclusion of this study, that this study highlights the distinctive prevalence, cardiac presentation and outcome of MINOCA and MICAD. MINOCA patients characterized by low cardiac enzyme elevations and better echocardiographic results and experience better outcome compared to MICAD patients. So that is particularly requirement is effective management of MINOCA that focus on identifying and targeting its underlying causes. So these are the references. Thank you very much for giving opportunity for presentation.
Thank you. That
Hello.
was a brilliant presentation. So any questions from the audiences?
I'm based at Baragwanath Hospital, Krisani Baragwanath Hospital, which is in Southern Africa. So we looked at balloon valvuloplasty for valvular pulmonary stenosis, and we looked at the experience that we had over 30 years. Just as an introduction, congenital pulmonary valve stenosis is one of the most common congenital cardiac defects. It accounts for 8 to 12% of all congenital cardiac defects, as per literature. Previously in the past, before the introduction of valvuloplasty, patients were candidates for surgical valvotomy. In other words, they were only managed surgically. But with recent with advances and more research done, then the procedure of balloon valvuloplasty was established. Cutaneous balloon pulmonary valvuloplasty has been the preferred alternative treatment since its introduction in 1982 by Khan et al. This procedure has reported success rates of approximately 88% worldwide. The aim of our study was to look at the efficacy and safety of percutaneous balloon pulmonary valvuloplasty over the last 3 decades at Chris Hani Baragwanath Academic Hospital in Johannesburg, South Africa. We did a retrospective descriptive analysis at our hospital. Essentially, we evaluated all patients who underwent balloon valvuloplasty of the pulmonary valve from 1985 to 2019. I must make a mention that in the earlier years, in this study, this procedure wasn't done that much. Like in the first 10 years of our study, this procedure wasn't done. They only did, I think, about 1 in 10 years, only from the 2000s. That's when the numbers increased, and thus the patient population is not a lot because it's something that was established a bit later. Data was extracted from our electronic pediatric cardiology database at our hospital, and we did not exclude any patient from the study. Descriptive statistics were presented continuous variables as means and standard deviations for normally distributed data, and we used medians and interquartile ranges for skewed data. The Shapiro-Wilk test was used to test for normality of the pressure gradients across the pulmonary valve, and the Mann-Whitney U test was used to compare medians. We considered a p-value less than 0.05 as significant, and we used Stata to analyze our data. Just the definitions of, because I'm going to make use of this word, severity of pulmonary stenosis. Severity of pulmonary stenosis in our center or in our country is based, and most literature is generally based on echocardiographic derived Doppler gradients. We consider mild pulmonary stenosis as a Doppler gradient less than 36 millimeters of mercury. We consider moderate pulmonary stenosis as a Doppler gradient between 36 and 64 millimeters of mercury. Then we consider severe pulmonary stenosis as a Doppler gradient greater than 64 millimeters of mercury. I need to also define what we used as a definition of saying this procedure was successful based on the literature, and this is what I came across. So we considered the procedure a success if the pressure gradient after the procedure had dropped by more than 50% of its initial value. That's what we considered a successful balloon valvuloplasty. A suboptimal result is defined. We defined it as a pressure gradient drop of between 25 and 49%. And what we considered unsuccessful is if the pressure gradient reduced by less than 25%. So we were looking for a drop in the pressure gradient across the pulmonary valve of more than 50% for us to say this procedure is successful. These patients all underwent cardiac catheterization, obviously to go through the procedure. Then we measured the peak-to-peak systolic gradient across the pulmonary valve during cardiac catheterization. The balloon choices we used a compliant balloon for the pulmonary valve. And with balloon sizing, essentially we used a balloon size which is at least 120% of the pulmonary valve annulus. I must make a mention that because in the earlier years of the study there was not much experience of this procedure, a higher annulus was used of 130% in the first few years of the study, actually first decade of the study, because very few cases were being done and the clinicians were still getting experience with this procedure. So just to go through our results, the total number of patients was 68. Like I mentioned, most of these patients were from the 2000s. From 1985 to 2000, I think only very, very few patients, like just about 10 or 20 patients were done because the clinicians were still learning how to do this. And then the numbers increased later on in the study, and they've increased even more. So in our study, we found that 7.4% of the patients were less than 1 month. 93%, which is the majority of the patients who underwent this procedure, were more than 1 month. Most of the patients were male, and the biggest indication for this procedure was severe pulmonary stenosis, which I defined as a peak gradient more than 64 millimeters of mercury. There were few patients, about 21%, who were moderate pulmonary stenosis, defined as a gradient of between 36 and 64 millimeters of mercury. These were the data on echocardiography and cardiac catheterization. The mean pulmonary valve annulus for our patients was 11.2, with a standard deviation of 3.9, and this is in millimeters. The mean balloon size was 13.1, and the ratio of the balloon to the pulmonary valve size was 1.169. As reported in the literature, you want a ratio of 1.2:1, so our ratio was more or less that. But like I said, in the earlier years of the study, they were using 1.3:1, which was associated with a higher rate of complications, which resulted in us reducing this. We had a good outcome comparable to what has been presented in the literature. We had a success rate of 88.2%. So 60 of the patients had a good response. We had a suboptimal pressure reduction in 7.4% of the patients, and 3 of the patients ended up not having the procedure because of other complications. All the patients who did not respond to this procedure had a dysplastic pulmonary valve. This is something that's been reported in the literature, that patients who have a dysplastic pulmonary valve usually don't respond to this procedure. But in our setting, even though we know they don't respond, we always try to balloon them first, because we want to avoid open heart surgery where we can. Then only when they don't respond, then we present them to the cardiothoracic surgeons. This was the pressure gradient. So before the balloon dilatation, the mean pressure gradient, pressure gradient was 79, with an interquartile ratio of 60, range of 64 to 102. A good response. The mean pulmonary valve, gradient, across the pulmonary valve was 33. Which was a good response. The median was 33, and the interquartile range was 23 to 40, and this was statistically still significant. As I mentioned before, I think I went back. So the reasons, as I mentioned before, the reasons why our patients, a few of our patients, 5 of the patients didn't do well. These are the patients who had dysplastic valves, so in other words, valves that are thickened and cauliflower-like, that don't respond very well to ballooning. This is mostly associated with Noonan syndrome, and this was seen in all of our patients who didn't respond to ballooning, as defined by a pressure gradient drop of more than 50%. These are the complications that we came across. We didn't have a lot of complications, like I mentioned, but we did have few patients with complications that are not really new. They have been reported in the literature, so we were prepared to manage these complications. One of the complications that is described is suicide ventricle. I would explain what that is. This was seen in 2% of our patients. We had 1% of our patients had reperfusion pulmonary edema. We had moderate pulmonary regurgitation in 25% of our patients. 3% of our patients had severe pulmonary regurgitation, which we do not want, because this will end up making the patient need a pulmonary valve replacement. And in 1% of our patients, we had patients who had a ruptured chordae of the tricuspid valve during the procedure. So severe pulmonary regurgitation following this procedure was observed in the first decade of this study, and we found that the reason why these patients developed severe pulmonary regurgitation was because bigger balloons were used, and that is why we decided to go down. So before, we used in the earlier when we were still getting experience, we used a pulmonary valve annulus ratio of 1.3:1, but this had problems. It resulted in the development of severe pulmonary regurgitation. So as a result, we went down to what was described in the literature, to 120%, or 1.2:1, which is what we now use, and that is associated with a reduced risk of pulmonary regurgitation. So congenital pulmonary valve stenosis is one of the most common congenital cardiac defects, and it's got a good outcome if treated correctly. The pathologic features of pulmonary stenosis vary, with the dome-shaped pulmonary valve being the most common type. In our cohort of patients, the majority of our patients, which is 92.6%, had the fused pulmonary valve leaflet and doming pulmonary valve type. This is the one you want, because these are the ones that respond very well to ballooning. And we had only 5 or 7.4% of the patients having dysplastic valves associated with Noonan syndrome. Majority of our patients, 79% of our patients, had this procedure for severe pulmonary stenosis, but we had a few who had this procedure for moderate pulmonary stenosis, and this is similar to other studies where patients undergo ballooning of the pulmonary valve with moderate and severe pulmonary stenosis. We used compliant balloons, which is also in keeping with the recommendation in literature. And the ratio in the later part of the study of the balloon to the pulmonary valve annulus, we didn't use greater than 1.2:1, because then we discovered the higher risk of developing severe pulmonary regurgitation if we use bigger balloon sizes. Although pulmonary ballooning of the pulmonary valve generally has a good success rate, a small number have complications that the interventionalist needs to be aware of. And in particular, I will mention pulmonary edema and infundibular obstruction. Shrivastava et al. From Escorts Heart Institute and Research Center in India described 2 cases of pulmonary edema soon after balloon dilatation of the pulmonary valve. These patients were treated with diuretics, inotropes, and ventilatory support, which is what we did for our patients as well, and they responded. So in our cohort, thankfully, a majority of the patients did not develop this complication. Only 1 patient developed pulmonary edema following this procedure. The patient responded to diuretics and ventilatory support. However, he did not need inotropes. One of the other complications includes infundibular obstruction after ballooning. This is also referred to as a suicide right ventricle. This may be related to the severity of the pulmonary valve obstruction. So patients who've got very severe pulmonary stenosis resulting in very high RV pressures are at risk of developing this complication. And in this cohort of patients, we need to prepare them. They need to be prepared very well. This complication is rare, and normally it results in cases where your RV pressure is suprasystemic before the procedure. In other words, it only usually happens if your RV pressure is higher than your systemic pressure before the procedure. Relief of the infundibular obstruction can be treated with admission of beta blockers. So the use of beta blockers helps these patients who develop this complication. And there has been a suggestion that if you find that you've got a patient whose RV pressures are higher than the systemic pressures, prophylactically, you can start these patients on beta blockers before as a way of preventing them from developing this complication. Follow-up of our patients. So 3 out of the 5 patients who had dysplastic valves had no change in the immediate post-balloon dilatation gradient. So their pressures didn't drop by more than 50%. They actually remained the same. So we decided first to monitor them over time and see what happens. A lot of them, surprisingly, had a further reduction in the pulmonary valve gradient at 3 months and required no further intervention. So in other words, the pressure didn't drop immediately, but it later on dropped. But that is something that we cannot explain. Only 1 out of the 5 patients went on to have surgery in the form of a transannular patch because the gradient remained high. One of our 5 patients who didn't respond well was unfortunately lost to follow-up, so I'm not sure what happened to her. And the 2 patients that I described who developed severe pulmonary regurgitation are currently asymptomatic, being monitored clinically, but they will likely need a pulmonary valve replacement in future. And this is why we don't want to use big balloons. We don't want patients to end up with a pulmonary valve replacement. But like I said earlier on, before we developed experience, these patients, we used bigger balloons, which resulted in the development of severe pulmonary regurgitation. So in conclusion, percutaneous balloon pulmonary valvuloplasty is a safe and effective treatment of moderate and severe pulmonary stenosis. The persistence of a gradient is associated with the presence of dysplastic valves, mostly in patients who are syndromic. These are your Noonan syndrome patients. A quarter of patients develop moderate pulmonary regurgitation, while a few develop severe pulmonary regurgitation, usually related to the size of the balloon. Balloon sizing of not more than 120% of the pulmonary valve annulus is associated with the reduced risk of developing severe pulmonary hypertension. Thank you.
Thank you so much for presenting with such clarity, ma'am. Any questions from the delegates?
Operation, which is the NICE operation. The problem is when we have infection in the aortic prosthesis, which poses a significant challenge for vascular surgeons because this treatment requires explantation of the aortic grafts followed by restoration of blood perforation, which is a very challenging technique. The neo-aortoiliac system, the operation, it was first described about 20 years ago and has provided a new perspective on this lethal condition. The problem with the NICE operation is there are some unforeseen difficulties with this operation, And these are when there is a large size mismatch of the veins and the aorta, or when there is an inadequate length of the harvested vein, or when this vein has fibrotic stenosis. Recently, we encountered two cases in which the superficial femoral vein was too short to perform the NICE operation. So we treated with a combination of a silver impregnated dacron graft and the NICE technique. This is a variant of the NICE technique which we think that can preserve the benefits of the operation in the infected field and expand this applicability in other various situation. So I'm going to present you the two cases. The first one was a 73 years old male patient was admitting to Untitled General District Hospital due to an abscess in his groin. From his medical history, we saw that there was a repair of an abdominal aortic aneurysm with an femoral bypass 3 years ago. The computed tomography, as it's shown in the figure, revealed a pseudoaneurysm of the right common femoral artery at the site of the anastomosis, but also it revealed inflammatory perigraft tissue extending to the whole retroperitoneal periaortic space, and moreover a psoas abscess. So we proceed to the operation. After receiving the intravenous antibiotics, we urgently proceeded because the first, as I have already told you, the patient was admitted first in another hospital. Then, when the patient came to our hospital, we urgently proceeded to the operating room, and under general anesthesia, the graft was completely excised. The aortic wall and the surrounding tissues were debrided, and the peritoneal irrigation was performed using an antibiotic solution. Then we wanted to proceed to the NICE operations, so the bilateral femoral veins were harvested in their total length by extending the dissection beyond the adductor magnus tendons. However, we saw that the lengths of both femoral veins were inadequate, so the restoration of blood flow had to be accomplished, and we accomplished this using a composite graft. This is the image of the operation after it was completed. A short segment of a bifurcated silver-coated graft was proximally sutured to the infrarenal aorta, and the distal graft limbs were anastomosed to the venous conduits. And these venous conduits, these femoral veins, were then linked to the femoral bifurcation. Owing to this configuration, the use of the prosthetic graft was only in the contaminated areas was obviated. We only used the silver graft to the proximal anastomosis, and this helped us due to the significant mismatch of the vein and the aorta. The result of this case was that after 5 days in the intensive care unit, the patient was transferred to the ward, and despite some minor problems that were treated conventionally, the post-operative course was uneventful, and so he was discharged in the 20th post-operative day in a good general condition. The second case is a 64-year-old male who sought medical attention for recurrent evidence of fever and discomfort in his left thigh. He had a medical history of aortic femoral bypass owing to tertiary-level occlusive disease 4 years prior. The CTA revealed a retroperitoneal periaortic mass on the left psoas extending downwards so far as the mid-thigh. Graft infection and abscess formation was suspected, of course, and blood cultures were taken, but they failed to exhibit any pathogenic microorganism. But also there was another problem, an inflammation near the cecum in the right limb of the graft. So we understood there was problem in both the limbs of the bifurcated graft. So the patient was administered intravenous antibiotics, and then under general anesthesia, we proceeded to the operation. A long midline incision was made, and the transperitoneal access revealed, So we just saw a fistula between the sigmoid colon, the left limb of the diacron graft, and the erosion of the second in proximity to the right limb. So there were both problems. Thereafter, the entire graft was excised, and the aortic wall and the surrounding tissue was debrided and sent for culture. And retroperitoneal irrigation was performed in a standard way using the antibiotic solutions. We proceed in the same operation. We just harvest the right femoral vein in the total length because beyond the adductor hiatus. But the problem was that, however, the length of the harvested femoral vein was considered inadequate despite the preoperative planning. As you can see in the picture, we tried to use all the femoral vein up from the whole length, but the length was inadequate. So we proceeded to this variant of the NICE operation. We just used a silver-coated dragon graft in the proximal area to anastomose it with the aorta, and we used the femoral vein as a limb to anastomose it with the femoral artery. Considering the thrombosed left limb of the graft sufficient collateral circulation, we didn't anastomose the left side, and so we proceeded only restoring blood to the one leg. During the same procedure, sigmoidectomy and primary repair of the second lesion had to be performed. So to say something about that, the aortic graft infection is a life-threatening complication. It's not so often, but it's not so rare, and its management is considered one of the more demanding situations in vascular surgery because it requires explantation of the whole infected graft and debridement. There are various approaches have been presented as a treatment plans. They used the first gold standard was used to be the extra anatomic axillary bifemoral bypass and to reperfuse the limbs, followed of course by the excision of the whole infected prosthesis. But in 2006, a meta-analysis by Dr. O'Connor challenged the status of the extra anatomic bypass as the gold standard technique, and they demonstrated several advantages by in situ graft replacement over extra anatomic bypass. So from 2006, the main treatment became the in situ bypass. There were several in situ techniques have been described. Each technique demonstrates its advantages over extra anatomic bypass. The in situ technique involves the use of wide variety of grafts. There are many of them, such as antibiotic bonded grafts, silver-coated dacron grafts, or cryopreserved arterial grafts, also homografts and xenografts. The NICE technique is a method of in situ reconstruction of using autologous veins that offer significant advantage over other techniques. This operation was first reported many years ago, and it's a complex vascular surgery that uses patients' own deep leg veins, the femoropopliteal veins, to reconstruct the infected or diseased aorta and iliac arteries, primarily for severe aortic graft infections. It offers durable infection-resistant grafts, but are lengthy procedures. They are challenging procedures and demanding procedures with many risks, like compartment syndrome requiring fasciotomy. The operation involves harvesting the veins, creating new arteries, and it's, as I've said, a very demanding procedure. This is the configuration of the NICE operation, and we see that after harvesting the veins must be reconstructed into bifurcated conduit. But the problem is that for diameters up to approximately 27 millimeters, a single femoral vein can be beveled to accommodate the diameter discrepancy. But when the diameter exceeds 27 millimeters, we use the pantaloon technique as it's shown in the figure, and the two grafts are sewn together proximally to create a larger proximal orifice that can be sewn better to the aortic stump. Alternative, we can create a V patch on the aorta to create a decrease in the diameter of aortic prior to sewing this to the vein graft. In the image, we can see the various configurations of the femoral vein that are used to create the neo-aortoiliac system. This is the vein harvesting that we must take the whole femoropopliteal vein. So the goal of this treatment is to improve the overall survival. Conversely, almost this operation should have the least impact on patients already poor condition, because we must not forget that these patients are patients in poor condition. And unfortunately, despite the significant progress in perioperative management, the mortality and morbidity rates remain high. The optimal conduit for use of aortic grafts remain controversial. There are many, all types of conduits present each one limitation, and the success depends on many factors, mainly the patient's comorbidity and the severity of the infections. In recent meta-analysis showed that although the construction may be considered as a first-line treatment, choice of the conduit should be based on variables. The silver-coated dacron graft have emerged as a reasonable option for the treatment of infecting aortic grafts. Their granting availability and low rates of secondary procedures. In a presentation of Byzantine et al. The Byzantine compared cryopreserved arterial homografts that they were considered very well conduits with the silver dacron grafts for abdominal aortic infections and found no significant differences. So, silver-coated grafts have several advantages, like that they do not contribute to antibiotic resistance. They are considered quite effective in a wide range of bacteria, and they are available in different sizes and types. That's very good for the surgeon because they have showed versatility, which allows to be straightforward and stable to use. So we present these two cases of aortic graft infections, and although our original strategy was to perform the classic NICE operation, in view of the suboptimal femoral veins intraoperatively, we used a composite graft attempting to combine the advantages of the NICE technique and these of the silver-coated dacron graft implantation. Autologous femoral veins were utilized as a durable conduit in the place less prone to reinfection in the contaminated inguinal hernia, while the silver impregnated graft was placed in the more proximal part of the operation near the aorta. After removing the infected prosthesis, we created a composite graft. This was a short segment of the silver-coated graft and long femoral venous limbs. In view of the inadequate length of the vein conduit and considering that the cause of the infection was confined distally. So, when we used this composite graft, rather than the entire silver-coated graft, we thought that the reinfection risk would be theoretically much less. This is not the first variation of the NICE technique, because variations of the NICE technique have been previously published. In one case, the preservation of a segment of the affected synthetic graft was combined with the use of both deep and superior veins, and in another case, there was unilateral inline replacement of the aortofemoral graft limb. But we present a variant NICE technique in which a short segment of silver-coated dacron graft was used in the proximal part near the aorta, and this was combined with the autologous femoral veins that were used in the distal part in a composite graft. Some advantage of this variation is that the approach creates a balance between the advantage and disadvantage of other types of in situ reconstructions. It shortens the duration of the operation because one problem of the classical NICO procedure is that it requires a considerable operative time, approximately 10 hours. Therefore, it should be reserved for patients who are hemodynamically stable. Another advantage is that confronts these size mismatches and confronts also the inadequate vein length. Uh, our variation of the NICE technique proved to be both versatile and efficient, and it may be significantly useful in young patients, particularly in those their infection is confined distally to the pelvic or to the groin. So, in conclusion, we must say that for the treatment of aortic graft insection, a variant NICE procedure using a composite content of silver-coated dacron graft and autologous femoral veins is a feasible technique in bailout situations where the NICE technique alone cannot be completed because of the suboptimal femoral veins. Dear colleagues, Madam President, thank you very much for your attention.
That was truly a very informative presentation, sir. Practical, relevant, and well delivered. Thank you so much, sir. I now invite Jing-Un Chow from Aberdeen Royal Infirmary, UK, to present his oral.
Pulmonary vein isolation using cryoablation of radiofrequency ablation. It's a very common procedure used to achieve rhythm control in somebody with atrial fibrillation that are not responding to the medical treatment. So I'm just going to talk about this cryoablation briefly to provide some insight to all of you about what cryoablation really is. And so cryoablation has emerged as a very successful therapeutic options because of its safety and also its efficacy to achieve rhythm control in somebody with atrial fibrillations. There are two different types of approach used previously: cryoablation and the conventional radiofrequency ablation. Recent study has shown that cryoablation is more effective because of its single shot circumferential approach, which does not create any conduction gap as compared to the conventional radiofrequency ablation, which uses the technique of point-to-point application of the energy. So the aim of this audit is to investigate the recurrence of atrial fibrillation and the long-term effectiveness of cryoablation, in addition to further intervention during follow-up to assess and evaluate the treatment success rate based on patient-reported symptoms. The other aim is to evaluate the success rate and the safety of this procedure using the cryoablation balloon in the patient cohort, in our patient cohort. So this is a retrospective study which was done in one of the tertiary hospitals in the UK, Aberdeen Royal Infirmary. And there was 181 cryoablations performed during the study period, and 102 patients were selected, and all of them have got atrial fibrillation, which was not responding to any medications. Therefore, decision was made to perform pulmonary vein isolation. The study period of this audit was between January 20 and between January 21 and January 2019. And 79 patients was excluded due to numerous reasons. 6 of the patients excluded died during the study period, but the death was not related to the procedure itself, but due to some other reasons. 3 cases were excluded because the procedure has to be abandoned. One was because the patient collapsed during the procedure due to pulmonary embolism was confirmed at later investigation, and therefore the procedure was not completed. And one patient was found to have early arterial pseudoaneurysm or fistula, and therefore not fit for the procedure. And lastly, one of the patients was not tolerating the procedure because only the local anesthesia was used, and therefore the procedure was also abandoned because of patient intolerance. So this is the graph. As you can see here, the ablation volume at Aberdeen Royal Infirmary from 2012 to 2020, there were 181 cryoablation performed during this period of time in order to abolish AV node reentrant tachycardia, CTI dependent atrial flutter, and also refractory atrial fibrillation. So the primary outcome of this audit is recurrence of atrial fibrillation. This can be divided into early and late recurrence of atrial fibrillations. And the definition of early atrial fibrillation recurrence is AF which lasts for 30 seconds or more within the first 3 months of ablation. This is because of blanking period, which we will discuss later in the next few slides. So I'll just talk about the result briefly. After the initial blanking period of 3 months, 36 patients continue to experience AF, and this is defined as late recurrence. So this graph summarizes the primary outcome of cryoablation. As you can see, 43 patients did not have any recurrence of atrial fibrillation after the procedure was done. 11 patients has developed early recurrence in the first 3 months after the procedure was done. And 12 patients has developed late recurrence without any early recurrence. And the remaining patients, 36 of them, has developed both early and late recurrence. All the patients in this study were followed up regularly after the procedure. Patients were first reviewed at 1 month by the cardiac rhythm management nurse, and then 3 months later in the clinic at different intervals. Because some of the patients are from different regions, so they are reviewed at the peripheral hospital. During the follow-up, it was found that in the recurrence group, there were 19 patients who undergo a repeat ablation in the first 24 months due to several reasons. So this pie chart shows different reason why those patients undergo a repeat ablation. The most common reasons identified here is pulmonary vein reconnection, which contribute to the highest rate of atrial fibrillation recurrence. The other endpoint I would like to talk about is the safety in terms of procedural complications. We found that 90 procedures were complication-free, and the rate was 88.2%. There is a few complications identified, as you can see in the table below. First of all, the most severe complication is pericardial effusion, which can result in cardiac tamponade. There are 3 incidents of pericardial effusion after the ablation, and this was addressed with immediate pericardial drainage to relieve the symptoms. Another complication identified was vascular access. 3 patients developed hematoma at the vascular side, either the femoral or the radial side, and this was managed with just manual compression. The most complication identified is phrenic nerve palsy, but this is usually self-resolving after a few months. And according to the literature, there's a few other complications such as thromboembolism, atrial esophageal fistula, pulmonary vein stenosis, but in this study, none of these complications were identified. This is because cautious efforts were made in order to prevent such complications. So as we mentioned earlier about the blanking period, and in this study, 46.1% experienced early recurrence, but this does not mean that the procedure has failed because of the blanking period. So we mentioned about blanking period earlier on. I'm just going to explain briefly about what blanking period is. So during this blanking period in the first 3 months after ablation, recurrence of atrial fibrillation is merely a reaction to the procedure itself because of the transient inflammation caused by the ablation. And the ablation lesions are not mature enough or not healed with fibrosis entirely in the first 3 months. For this reason, immediate ablation is not recommended within the first 3 months according to the current guidelines. And if the patient do experience symptomatic atrial fibrillation, this is normally managed with anti-arrhythmic drugs instead. However, there is an exception. One patient was deviated from the protocol, requiring repeat ablation in just 10 days after the first procedure because of highly symptomatic atrial flutter. Therefore, this should be contemplated carefully if the repeat ablation is deemed necessary in order to avoid any unnecessary repeat ablation. That is because most of the patients who develop early recurrence actually become free from atrial fibrillation even without repeat ablation. There's a few other factors which contribute to the success of cryoablation. Most of the patients have got multiple comorbidities, such as heart failure, hypertension, previous coronary heart disease, and all patient comorbidities were treated concurrently with lifestyle modifications. So cryoablation is deemed a safe procedure because most of the patients were referred from the peripheral hospital or the district hospital to the tertiary center, because in tertiary center, it is equipped with emergency cardiac support in case of any complications. This is crucial because one of the patients actually developed cardiac tamponade, which resolved on immediate pericardial drainage. To prevent further catastrophic event, there's a few prevention, such as high output pacing. This was done prior to ablation, which has successfully captured for impending phrenic nerve damage, and therefore that particular lesions in the right pulmonary vein was not isolated due to high risk of phrenic nerve damage. Cryoablation delivered cryo energy to each area at a nadir temperature of negative 70%, negative 70 degree, which can also cause cryotrauma to the patient. And for this reason, all patients were given prophylactic lansoprazole to prevent cryotrauma, and all patients were monitored carefully during the follow-up to exclude pulmonary vein stenosis. This has perhaps contributed to the low rate of major procedure complications, which only accounts for 11.8% of the entire patient cohort. So, in conclusion, pulmonary vein isolation with percutaneous balloon cryoablation, it's a relatively safe procedure and effective procedure in order to achieve rhythm control in patients with refractory atrial fibrillation. A large proportion of the patient experience improvement in their quality of life after a single cryoablation and also repeat ablation during follow-up. And this is justified by high incidence of freedom from atrial fibrillation. That is the end of my presentation. Thank you very much. I'll stop sharing my slide now.
Yes, that was a truly excellent presentation, ma'am. Thank you for enriching our conference with your work. Thank you, ma'am. So we now move on to the next e-poster presentation. Unfortunately, Sabrina could not